folks, thank you. I see also two wonderful people there in the audience. Thank you very much for coming this morning. I don't know if you can hear me okay. Good, excellent. I'll just move that a little closer. We're very, very thankful to Mercy this morning for putting on this wonderful presentation, as well as to our other host, Medtronic, who has helped organize this in terms of aneurysm awareness. This brings to light, of course, that abdominal aortic aneurysms are something that we need to pay attention to. And we're very thankful to the FDA, actually, for bringing this about and making changes in the way we can treat aneurysms. 1999 was a very, very important year as far as vascular technology was concerned and aneurysm repair was concerned. That was the year, especially October in 1999, when we went from repairing all aneurysms in an open method, the traditional open surgical repair, and we were able to go to our newest endovascular repair model, which now is currently the standard of care across the country. Since 1999, I personally put the first one in 1999, December the 3rd. I remember that day very, very well. And it was a very tough case. It was our first little grandmother that we had in East Tennessee, and she did very, very well with the surgery and got through it. And as I said, since then we have now gone through at least 5 or 6 different generation changes in the way the graft itself is prepared and made. So over the past 12 years, we've really made significant improvements in the actual technique itself. A lot of famous people had abdominal aortic aneurysms. As you can see from the slide there, Albert Einstein, one of the most famous scientists, had an abdominal aortic aneurysm. And initially what they did, they wrapped his aneurysm up with cellophane. Can you believe that? Saran wrap. They just took a piece of saran wrap and wrapped it up, and he actually survived several years, probably because of the scar tissue that had formed around it. Lucille Ball had one, George C. Scott had one, and Conway Twitty. So all people that you recognize, all famous names that we know. So nobody's immune to this process. And there's approximately 2% of the American population that has an abdominal aortic aneurysm. So if you extrapolate the figures, we have about 300,000 Americans. We're closer to about 6 million people, actually more so than the 2 million that we're talking about today. Now, an abdominal aortic aneurysm is a bulge in the stomach. And typically, as this bulge starts to grow, it can get to very dangerous dimensions, and we'll talk about that in a few minutes. As you can see from the slide here, the aorta, which is where the aneurysm resides in, is below the kidney arteries almost 90% of the time, and it starts to slowly grow, as I said, from side to side, and top to bottom. And then basically, when it gets larger than 5 centimeters, it has a very large statistical chance of rupturing. Now, who's at risk? Obviously, you're here for a reason, because you feel that you want to know whether or not you have an aneurysm. I think that's very important to know. And we start our screening at the age of about 55, especially sometimes younger, especially if you have a strong family history. And as you can see from the second line there, yes, there is a genetic predisposition and some hereditary features involved here. So if someone in your family's had an aneurysm, you're at a little higher risk than the average population. Of course, smoking, hardening of the arteries, high blood pressure, diabetes, all these things do play a role, as well as COPD, also known as chronic obstructive pulmonary disease. So if you have bad lungs, of course, that also plays a role in how fast it grows sometimes. Other situations are if you've had a CABG, which is a coronary artery bypass. So if you've undergone a heart bypass, you're also at risk. Now, it's called a silent killer, and a lot of things are silent in medicine. You never know you've got a problem until it finally happens and occurs. And the best way to find this thing is by a screening process or an ultrasound that your family doctor asked for, or even a CT scan because he's looking for other things. And that is the most fortuitous way to find it, because all of a sudden you know about it and you can follow it along and prepare yourself for it. Now, if you do have symptoms, the symptoms usually are feeling a pulsation in your stomach. you feel your stomach at night, you think you've got a pulsation, you say, boy, that's beating a little too much. So the best thing to do is tell your family doctor. Your family doctor will order an ultrasound, and that'll tell you immediately. Now, for those of you that are here today, you'll know today whether or not you've got a little aneurysm or a small one or a big one. So we will tell you right away. So don't be worried about that. The other thing that can happen, the other thing that can sometimes present as, of course, is back pain. A lot of people think it's arthritis. A lot of people think it's, maybe it's just my old age, but really it's the aneurysm itself beating along the vertebral column, or what we call the backbone. I had an interesting case a few weeks ago, and there was a patient of mine who was walking around at work, and he was up in the mountains and doing his regular activities, complaining about back pain, and immediately he was taken to the hospital. They did an ultrasound. They found a 13-centimeter aneurysm. That's very, very large. He was immediately flown down here by Lifestar, and we were able to go ahead and repair it that same day. So those are the things to think about when you ask yourself what you need, what the symptoms are. Again, abdominal aortic aneurysms are the third leading cause of death in sudden death in men over 60. And again, remember the figures I told you. There's about 6 million of these around the country, and many of these are undiagnosed. As far as rupturing and surviving, I always tell everybody you're always better off to go ahead and get the surgery, because the surgery gives you the best opportunity to go ahead and get treated. There are always risks with it, but if this thing ruptures, as you know, there's less than a 50-50 chance of survival, and that's very important. If we are able to do the surgery, and your vascular specialist advises you to do so, your chances of survival are around 90%, which is excellent. Now, again, back to the screening. Early detection is the key. You may have a small aneurysm. That's something we'll want to follow along slowly every 6 months to a year, depending on its size. And all the hospitals, we certainly are very well equipped here at Mercy to follow them along in the radiology department, in our offices. And as long as you're with a vascular specialist that knows the disease and the pathophysiology, you'll be in good hands, and that's very, very important. Now, screening does help because we identify people who have these aneurysms. We anticipate finding about 2 or 3 today, the whole day. And that'll be very important, because if we follow these people along, we'll be able to tell exactly what size they are and when they need to be treated, and that way we'll be able to save their lives. Perhaps not this year, but in the next couple of years, and that is also very important, because again, we're saving lives in the future, and that's very important. Don't forget, once you become part of the Medicare population, you are allowed one free screening. It's called the SAVE Act. That was put into Congress several years ago. It's part of the overall Medicare physical that you're allowed to have, and that is part of the treatment that, of course, that your family doctor and your internist should be able to provide for you. So remember to ask for it if you haven't already had it done. There's a couple of other things under that SAVE Act as well that you're allowed to have, and it's important to know that. Now, we talked a little bit about size. I did mention the word 5 centimeters. That's when these things become critical. And there is a 25% chance of rupture with it after it hits 5 centimeters. Now, as you can see from the slide, if it's less than 4, we typically see you every 6 months to a year. If it's between 4 and 5, we may become a little more proactive and see you about every 6 months, and even get a CT scan sometimes to take a look at the vessels themselves and make sure that you're not outgrowing our potential for endovascular repair. And I do stress endovascular repair as opposed to open repair, because I think it gives everybody the chance to bounce back a lot faster. Now, your vascular specialist will make that decision for you, so there's a lot of intricate, complicated features that go into trying to decide when to fix this. So 5's not an absolute number. It's a number that we go by scientifically in the literature, but it's not the main number that we treat. So remember that. Now, as it grows larger than 5, the risk of rupture becomes even larger. At 6 centimeters, it becomes 35, and at 7 centimeters, it becomes almost 40% chance of rupture. So I don't know how that guy's aneurysm got to 13 centimeters. That's really astounding as to what the human body can actually do. Now, we do have two options. Remember, 1999 was the first year we were allowed to start implanting aortic stent grafts. Again, a great year for technology and a great year for the FDA to be able to allow us to do so. The top slide, as you can see, is the open surgical repair, and that indicates that you've got a long incision from the bottom of your breastbone all the way down to the top of your pelvis. It's about a 12-inch incision. It takes about 8 weeks to recover. It really is a longer course. It's a very good repair. We've always been able to do that. But as I said, standard of care really anymore, I think one would easily say that the endovascular stent graft repair is the way that most surgeons, most vascular specialists are now pursuing across the country. I would say that approximately 95% of all aneurysms can be repaired endovascularly, at least in my hands. There are some certain situations and features that do make some aneurysms a little more complicated, but those two can be overcome with different techniques and different methods. And again, the more experienced your vascular specialist is, the more able he is to find a solution, endovascular solution for treatment. Now, as you can see here, a live picture of the open surgical repair. Again, it takes about 4 hours to do the whole procedure. And again, the recovery room, you stay in the ICU a couple of days, and again, about a week or 10 days on the floor trying to recover. It is certainly, a lot more blood loss is involved as well. With the endovascular repair, as you can see the difference, we really have two very, very small incisions below the groins. They're usually they're not very painful. I mean, it's a big difference between a larger incision in the stomach with all those muscles that you have to cut across, as opposed to the small groin incisions. People tolerate these very, very well. The procedure can last, again, anywhere from 1 to 3 hours, depending on the complexity. And of course, the patient's able to eat that same day, which is not usually possible with the open technique. The blood loss is much less. Then the hospital stay is much less. Typically, we can discharge people anywhere from 24 to 72 hours after the procedure. Most people go home the second day, and that's a huge, huge advantage over the open repair. Now, again, remember, afterwards, we do follow the stent grafts, even though I've been personally involved with them for over 12 years, and I found that I recently celebrated one of my 10-year anniversaries with one of my patients who's had it in for 10 years, and his stent graft looks as good as the day that we implanted it. So, as I said, we've got a lot of experience here at Mercy as far as implanting endovascular devices, and they have withstood this test of time. The most common question I get is, well, Dr. Pliagas, how good is this for? And I say, for the rest of your life, and I mean that. So that's an important thing to know. I'm not going to bore you with some of these selective case studies, but you can see some of the complexities that we've got. Not everybody's built the same. Of course, the nice ones are the straight aneurysms, where you don't have a lot of curves and a lot of tortuosity. And in these slides here, you see that our stent grafts are able to actually take a lot of twists and turns. And the better generation ones that we have coming up, thankful to the new technology that Medtronic is bringing to the scientific world, will allow us to even traverse even more difficult aneurysms. Now, again, I'm going to leave you with this final slide. We do have the answers. If you've got an aneurysm, you want to know about this. You want to be able to follow it. You want to have a good vascular specialist following you, telling you when to go ahead and treat this. A lot of, as I said, you see Joe Theismann's picture up there. His dad actually had an aneurysm, and that's why he's so involved in this. And the orange suspenders you'll all get today, of course, is indicative of our push to make sure that there's a lot of awareness around the country for abdominal aortic aneurysms. I'll finish off with this one thought. Remember, it's always better to try and fix them when you can, because when they do rupture, it becomes even more complicated, more challenging. I'll take questions after I'm finished here, but again, I want to thank Mercy Health Partners for allowing us to host this today, and of course our other co-partners in this challenge to fix aneurysm, which is Medtronic. And thank you, and have a wonderful day.